Thank you, Ibrahim. Once again, good evening, and thank you all for joining us. This session is organized by the Academics Department of MSAUN KNH. My name is Saadia, incoming fifth year, and I will be your moderator this evening as we explore a topic that is both fascinating and essential for every clinician: how to read and interpret a head MRI. We are really fortunate to have with us Dr. Mohamed, a rising star in the field of neurosurgery. Dr. Mohamed is a fifth-year neurosurgery resident and deputy chief resident at KNH. He holds a BSc in medical physiology, an MBCHB from UON, and MSc in medical physiology. In addition to his clinical work, Dr. Mohamed is a tutorial fellow at the Department of Anatomy and Medical Physiology at the University of Nairobi, and he also serves as a tutorial assistant at the Department of Biomedical Sciences at Aga Khan University. It's truly an honor to have him here tonight, sharing his vast knowledge and experience with us. Please join me in welcoming Dr. Mohamed. Doc, you're welcome. Go ahead.
Thank you very much. Can you hear me?
Yes,
Hello?
Doc, we can hear you.
Oh, thank you very much. Sorry, I think you'll have to project for me, Sadia. I had shared the slides earlier in the day. Okay, thank you very much. I really appreciate the kind words as always, and the entire team for spending your Sunday evening. I promise I won't take a lot of your time. I just wanted to probably put into a little bit of perspective, what you can be able to grasp about MRIs of the brain, because I think imaging is one of that a really important area, especially with regards to the brain. So next slide, please. These are the objectives that we have lined out for this evening. Next, please. Next. Okay, good. So MRIs are very important as a medical imaging technique. They were actually put into use from the late 70s to the early 80s, and they give a detailed visual of the internal structures of the body. In this particular scenario, we're going to focus on the brain, but MRIs are useful in very many other pathologies, including the spine, the abdomen, the pelvis. A lot of people in the colleagues from ortho department also tends to use it. So the basic principle of MRIs is that you have a very powerful magnet. That's why when you have patients who are going in, they are advised not to have any metallic objects that they are wearing. You don't go in with any oxygen tanks, or even patients who have pacemakers, as an example, they can be able to disorient the pacemakers. So as we all know, the body is essentially made up of your body cells, and in all of these body cells, you have the smallest structures, which are your atoms. Each of these atoms is going to have a hydrogen proton. We use hydrogen specifically because it's the first, it only has one proton. And what the magnet tries to do is that it tries to use a powerful radiomagnetic wave to create an image. So it creates this image by aligning. So just before we talk about the MRI, each of these particular protons are always in constant motion. And what happens is they are pointing in different directions. So what the powerful radioactive magnet does is that it's going to try to align all of these particular protons in one direction so that you can be able to try to create an image out of it. Now, the difference in MRI is that it doesn't use ionizing radiation, as we have seen in CT scans or as we've seen in X-rays, but uses these radio frequency impulses to be able to align all those protons that you have in a particular segment of your body in one particular direction. Then based on the alignment, it will be able to create an image which you can be able to see. Now, there's several advantages of an MRI. It's non-invasive and there's no ionizing radiation, as I've said earlier. It's very beautiful and very excellent for soft tissues, and it gives a distinct contrast. And this particular contrast in the different tissues will come about because the tissues contain different amounts of water. And based on that, you'll be able to see different intensities. That's the word that we use in MRI that would be able to be projected on the screen. And it's very excellent, especially with soft tissues. Then you can be able to do imaging in various planes, which is axial, sagittal, and coronal. Now, remember, we still have some limitations. They're very long scan times. An average MRI would take you anywhere between 30 to 45 minutes to do the entire imaging. As I said earlier, there are various contraindications, especially for patients who have pacemakers, metallic implants like the ones we have in orthopedics, or patients in neuro. We have implants that we've used in the brain, like to reconstruct the cranium. There are certain motion artifacts, especially depending on the quality of the MRI machine that you're using. So think of it like how you have your phone camera. You have a phone camera that's probably 8 megapixels. There's one that's 16, 32, so on and so forth. So same thing with the MRI machine. You would see there's 1.5 Tesla, there's 3 Tesla, and all this you're trying to be able to refine. So the scans that were earlier, you would see that they would have some motion artifacts, and occasionally you would have the image that you want to project not coming out as well as you would like. The other thing, as a final limitation before I move to the next slide, is because of the MRI machine. I'm sure most of you must have seen it. If not, please just pay a visit down to the MRI scanner we have at KNH. You would see that some people have claustrophobia. So getting into that tight space for quite some bit of time, some patients would feel uncomfortable. So you would have to sedate them, etc., to be able to get imaging. Same for children, for them to stay still in that particular place for a very long time. You would see that they would be uncomfortable. Now, you would see that some radiologists would use something like, asking the patient to put on headphones with music, or there'll be some music playing in the background to try to make the patient more comfortable and to try to have that loud sound not being as obvious. So those are some of the things I want to put out there. Next slide, please. Now, I think I've talked about this in terms of the principles that we have with regards to protons and hydrogen atoms aligning in a magnetic field. We've talked about radio frequency pulses that excite protons, which emit signals as they relax. Now, what is the difference? You will hear a lot of MRI scans being called T1 scans and T2. Now, the T1 and the T2 scans, the difference would be how the protons have been relaxed. The T1 would have the directionality facing for the protons in the longitudinal direction. So they have a longitudinal relaxation. And then you can be able to alter the radio frequency wave direction to make the particular protons face or have a transverse relaxation. So in each of these particular relaxation modes, you would have the appearance of various tissues depending on their water content, having different intensities. So for example, in T1, you would see that fat is bright and fluid is dark, or what we call black. And the right word to use there is that it's going to be hypo intense. Then in T2, when there's that transverse relaxation, you would have fluid appearing bright, whereas fat that has less fluid content appearing dark. So the differences would come in with regards to like brain matter, white matter versus gray matter, with regard to the fat content that they would have. For example, a white matter would have myelin sheaths, so it would have a higher fat content. So on T2, for example, it would appear brighter relatively compared to fat. And in between, you have bright, like white, and then different intensities of gray. And the differences in the imaging would come about because of that. Now, we also use contrast agent. The specific one that we use is called gadolinium, and it enhances areas, especially with a focus on the brain, those whereby the blood-brain barrier has been disrupted, and you would see that they would enhance with T1 with contrast gadolinium. Now, anatomically, I went through this in great detail last time when we were talking about the head CT scan. The main features on the brain that you would have are the cerebral cortices. You have your white matter, your basal ganglia, and your thalami. Then you have the ventricles. In this case, they contain fluid. So depending on which particular sequence, that's the right word to use, whether it's T1, T2 that you're using, then it would appear differently. Then you have your cerebellum, your brainstem. Then you have your various lobes, then your sulci and gyri, which can be landmarks for orientation, especially with regards to where a particular pathology is. Next slide. Okay, next. Now, I will focus a bit on T1 weighted MRIs, especially with regards to appearance of normal structures. And you will see that the more you look at these particular images, the more you'll be able to pick them up. So I'll just focus on all of them. Then you don't have to memorize each and every single one of them because there are very many tissues you can be able to get. Then I'll just give you one or two tips or tricks to be able to quickly identify depending on what MRI scan of the brain you've been given. Now on T1 plane without contrast, you would see that the gray matter would be intermediate. I would show you an image on the next slide that is darker than white matter. White matter would appear bright, and as I say, this would be due to myelin. And remember, the myelin is fat, and fat would appear as bright. CSF would have a low signal, and it would appear dark. Fat would appear bright, so you see like on the scalp or on the bone marrow, and then bone would appear as dark. There would be no signal. Now, the various findings in terms of pathology, you can use this for are tumors, you can use subacute hemorrhages, calcifications, and it's excellent for anatomical detail. So T1 MRI images, when you identify it, you'll be able to use it in great detail to describe the anatomy. Next slide, please. So the scan that I've shown you is an axial cut of an MRI. This is at the level of the lateral ventricle. So it shows you various structures. I wouldn't want to belabor the point, again, obviously because of time constraints, but the most obvious thing that you would see on these MRI scans on T1 is that you would see the CSF appears as dark or black. So on T1, that's what you would be able to see. Then the white matter is going to be bright relative to the gray matter. So you can see that there's great anatomical detail. You can be able to see the CSF in the subarachnoid spaces, and the CSF would be a good guide for you to be able to say that this is a T1 scan. Next slide, please. Now we move to T2 weighted MRI of the brain, or MRIs, basically because it's going to be the same throughout the body, but our focus today of discussion is the brain. The normal structures, you would have gray matter appearing as relatively intermediate, but would be brighter relative to the white matter. Now, remember that in the brain, the gray matter would be covering the white matter. If you remember the anatomy, then the white matter would be flowing down through the various tracts, coming down towards the basal ganglia, the thalami, down towards the spinal cord. So the white matter would be relatively darker in these T2 sequences because of the myelin that they contain, which obviously means that fat would appear intermediate to dark. Then CSF or fluid here would appear bright and it would have a high signal. So it will be relatively hyper intense compared to the surrounding. Then bone would appear as dark. So bone appears as dark both in the T1 and the T2. Now, I've had also some of students coming, and number one, they confuse even an MRI with a CT scan. A CT scan, you'll be able to see that the brain, the scalp, no, the bone, the skull would be very prominent. If you remember last time what I showed you, but on MRI, you wouldn't be able to see that because bone appears as dark. Now, T2 is good for pathology aspect. Remember, T1 is excellent for anatomical detail. So it's preferable when describing an MRI of the brain to start with the T1 sequences and again go in order while describing the anatomical detail. Then T2 would be able to describe the pathology. On T1, you'd still be able to see the pathology. So what is expected is that on T1, you go through the anatomy in detail as you go through the various levels of the brain, look at where the pathology is, and discuss the appearance. Is it hyper intense? Is it hypo intense? And it is relative to what? So, for example, if you have the scan being hypo intense on T1, then you would think that it contains some fluid because that is the appearance of fluid on the T1 scan. If you have the fluid and then you do your T2 and it becomes bright, then you're thinking that that is probably a cystic pathology. That's how you try to see it. If then it takes up the appearance of fat or something relatively closer to fat, then you can be able to say it is hyper intense on T1 and then it's hypo intense on T2. So the moral of the story here is that I want you guys to be able to see what particular MRI sequence you're looking at, whether it's a T1 sequence, whether it's a T2 sequence, and then based on what we have discussed in terms of the different properties relative to that where the fluid is or what it has compared to fat, then you'll be able to try to make some kind of a diagnosis. Next slide, please. So again, this shows us the different appearance of the pathology. Again, it's quite detailed. I wouldn't expect you, I mean, I am in neuro my 5th year, and in all honesty, I don't know every specific little detail of how it appears. But the common ones you're able to tell is especially with regards to the white matter, the gray matter, and the CSF. The CSF generally is quite a good guide in be able to telling you what kind of sequence you're looking at. So you see here, this is an axial cut of the MRI brain at the level of the lateral ventricle. You can be able to see the body of the lateral ventricle with the frontal horn and the occipital horn, and you can be able to see that fluid is bright. You can be able to see the fluid in the subarachnoid spaces in the sulci surrounding the brain, and you can be able to see that it's also appearing as bright. White matter here, if you compare it, it looks dark, but compare the white matter and the gray matter. So here, the gray matter would be relatively brighter than the white matter because the white matter has got more fat because of the myelin, and you would have it being darker relative to gray matter. So again, a lot of it is comparison. You're comparing it relative to a structure that is around to it, and you're looking at it down the grayscale. Next slide, please. So I think I've gone through this already. The T1 weighted is great for anatomy. And T1 weighted will be able to give us with contrast, with gadolinium contrast, and you're able to see T1 weighted with contrast if it picks up contrast. which means that it is well vascularized and there's a breach of the blood-brain barrier. T2 weighted is great or detects pathology, and you can be able to describe it in greater detail depending on what you've seen on T1. It also picks up quite some bit of edema, and the CSF is generally bright in this particular scenario. So far, I hope we are together. Next slide, please. Now, as I said, on T1, you can be able to give a patient with contrast because T1 is great for describing the anatomy. So the normal structures would appear same to that as T1. And on areas where there is normal brain tissue, there would be no enhancement because we expect the blood-brain barrier to be there. Vessels that would be surrounding, for example, you have the internal carotid, the middle cerebrals, the anterior cerebrals, the posterior cerebrals, the communicatings in between them. They would appear bright because remember gadolinium is transported through the blood vessels, but remember it's not going to be within the brain parenchyma. There would be some slight enhancement of the meninges that would be seen, but not very overt. Again, quite great for picking up details with regards to areas where there is breach of the blood-brain barrier or tissues that are highly vascularized because you'll be able to see you're comparing it relative to that of T1 plane. So we have T1 plane, and then we have T1 with contrast. So in summary, so far, we've gone through 3 different sequences. We've gone through T1 sequence, MRI sequence. We've gone through T2 sequence and the appearance of various tissues and the thinking behind why various tissues appear that. And now we're moving a step forward. We've talked about T1 with contrast, whereby you administer gadolinium contrast and you want to be able to see what would appear as bright. So in T1 with contrast, you're comparing it relative to T1 MRI. Next slide, please. Good. Now we have a different sequence or a 4th sequence that I would want to go through this evening is what we call FLAIR sequences. FLAIR stands for Fluid Attenuated Inversion Recovery, also called FLAIR in short. And these are quite useful for identifying lesions adjacent to cerebrospinal fluid. Now, if you remember, CSF would appear as bright on T2. So what you want to be able to see, because all fluid is not CSF in the brain. It can be edema, it can be any other fluid that you can be able to think about. The commonest one being edema. Now, what happens is in FLAIR, you're suppressing the fluid signal and you're improving the signal of non-CSF fluid. For example, you have a patient with a cystic mass next to the ventricles. On T2, you can be able to see that all of them are appearing bright. But what you want to see is the particular fluid, for example, cystic fluid that's within that particular abnormal pathology, if it is CSF, truly CSF or not. So based on the sequence that we have, you can be able to now, or you can suppress the CSF signal, and this particular FLAIR sequence would be able to pick up periventricular lesions. So if an area that has a pathology in the brain, because we're trying to define, remember we said soft tissue structures can be defined very well using the MRI. So if you have a tissue that you think has a cystic component, so on T1, it appears dark. On T2, it appears bright, similar with CSF. So what you want to be able to see is this fluid, particularly in that particular abnormality or pathology, is it a real or true CSF that is contained there? Because you would manage it slightly differently. So what you do is you null or you suppress the CSF signal. So if it's going to be bright and then it becomes darkened on FLAIR sequence, what you would see is that you think that that is a CSF because you've suppressed all the CSF signals. However, if the fluid still remains bright on a FLAIR sequence, what you have is that you think the cystic fluid is not CSF because you've suppressed the normal CSF, but it still appears bright. So flare sequences originate from T2. There's also a T1 with flare, but not very common. So you do your T2, then after T2, then you go to your flare sequence after suppressing the CSF. So you would see that fluid would appear, no, that no, fluid is not the right word to use here in flare, that CSF would appear as dark, but non-CSF fluid would still remain bright. I hope I'm making I'm making sense over here. So if you see the scan that's there, you would see here that the fluid appears dark. From the outset, you would think that this is a T1 because the CSF is appearing dark. But then if you see the white matter and the gray matter, they have similar appearance to that you have in your T2, right? So what is going to happen here is the fat would still remain a bit dark. You can be able to see that the white matter is relatively darker compared to the gray matter. I hope that makes sense. So gray matter, you'd see, is the one that is surrounding where the white matter is, but fluid is still appearing dark. And here is what we have called the flare sequence. I hope I'm making sense, but we'll have a discussion with questions. Next, please. So this is just a comparison of the same. I felt it would be good to see them across. For purposes of orienting audience members, white matter is shown as green. Gray matter has that sort of brownish yellow color, and the CSF has got that kind of light or luminous green. And you can be able to see the comparison with regards to the three common MRI sequences. CSF on T1 would appear dark, gray matter is gray, and white matter is white. But if you come to flare, because most people would confuse T1 with flare, CSF would also be dark, but you want to see what your gray matter is looking like. Your gray matter here would be relatively gray, and your white matter would be darker compared to your gray matter on flare. But on T1, your your white matter would be relatively bright compared to your gray matter. That's fine. Next slide, please. Now, there's also a final two different kinds of imaging with regards to a brain MRI that I want to discuss, what we call the DWI and the ADC. These ones are good in showing changes in cell density, and they help to differentiate between various lesions such as strokes or tumors. Now, the DWI and ADC maps tend to go quite closely together, and they have so much more detail just relatively compared to what I've put up on the slide. But their importance with regards to diffusion of water molecules across the tissues, and the diffusion weighted images would capture that, whereas the ADC map would complement the DWI by quantifying. So one is qualitative, the other one would quantify the movement. So it's good for detecting various pathologies such as strokes or tumors. So I won't really hammer the point too much. We can always have another discussion. I don't want to bore you too much with that. Next slide, please. Now, there are other additional MRI techniques, what we call MR angiography, that looks at the blood vessels or visualizes blood vessels. There's MRI spectroscopy that looks at the different tissues. For example, despite you doing the T1, the T2, the T1 with contrast, the flare, the DWI, and ADC, you still have some tissues or pathologies that would look similar across board. And we can go one step further and analyze the metabolic or metabolite concentrations. And there's some specific ones that we use using the MRI. And based on the sequence that they are able to produce or release, we can be able to see which tissues have higher NAAs versus cholines. So there's a bunch of them that we would use. And they can be used, for example, to differentiate between a TB abscess versus a bacterial abscess, versus a tumor like a glioma. And there's what we call functional MRI that maps up your brain activity. The areas that are lighting up are areas that are, for example, much more getting more blood supply. For example, if you're moving your right upper limb, you would think that the left frontal lobe would be lighting up more, especially in the motor strip, and that's functional MRI. Then there's perfusion imaging that assesses the blood flow, especially in strokes and tumors. So these are more additional MRI techniques that I want you to just have an idea about. But the main one I want you to get is the T1, the T2, and how to describe the MRI. Now, how do we apply this? We can go to the next slide. We use them to identify various pathologies, such as brain tumors, strokes, benign lesions, bacterial infectious, pathologies. We're looking at demyelinating diseases such as multiple sclerosis, etc., etc. Next slide, please. Now, how do we interpret this? With regards to reading, again, we can go to the next slide, please. We use a systematic approach, which is similar to what we had for the CT scan. So important to identify or verify the patient and the scan details. So you look at the name of the patient, the age of the patient, the sex of the patient, the date it was done. Then you want to be able to identify what kind of cut it is. Is it an axial? Is it a coronal? Or it's a sagittal? And ideally also, it's good to know at what level of the brain that you're looking at. So you're looking at it at the posterior fossa level, or at the level of probably the third ventricle, or at the level of the lateral ventricle. And then you want to talk about what sequence type. So I'm sure at the end of this particular discussion, you guys are able to discuss the different sequences with regards to T1, T2, T1 with contrast, FLAIR, DWI, ADC, and then was contrast used or not. Some of the MRIs that we have, you would see that they are able to see, they're able to write CO and con. Like if you see a con, you will say that that's a contrast that has been used for that particular MRI. So assessment of imaging quality is something that I just threw in there. It's good to just have an idea what you're looking at. If there are some motion artifacts, remember I told you it's very uncomfortable for most patients to sit still or lie still for 30 minutes as the MRI is being done. So you would have occasional motion artifacts which you think might be a pathology, but if it's not consistently appearing across the different levels, and if it doesn't tally with your clinical findings in the patient, then probably it is a motion artifact. Then you review the anatomy. As I told you earlier, ladies and gentlemen, anatomy is excellent for T1. You identify what are the normal structures. So for identifying the normal structures, you need to have your anatomy on point, just going through the different levels. So I tend to broadly say you're looking at the level of the foramen magnum, you look at the level of the medulla, then look at the level of the pons, look at the level of the midbrain, you come to the posterior fossa with regards to the cerebellum, then you come to the level of the sellar region, then you come to the level of the third ventricle, come to the level of the lateral ventricles, then you come to the cortical level. So you look at frontal lobe, look at parietal, look at occipital and the temporal lobe, and you're pretty much done with your MRI. Then you're also describing from out inwards, especially if you have a scan that is looking at the axial cuts. So you come from the outwards. Remember how I taught you last time? So you have your scalp with its layers, you have your skull, then you have your dura, arachnoid, then you have your parenchyma, all the way down to your ventricles. Then see what you can be able to see in a 3D manner. If you can compare this with what you see on your sagittal scan and your coronal scan so that you can make a 3D reconstruction. Then once you've described the anatomy using your T1 MRI, you use your T2 MRI to describe if there's any pathology, go to your FLAIR. Okay, so I normally like going to T1, T2, then you go to your T1 with contrast. Then you go to your T2. Remember we said FLAIR would commonly arise from your T2. Then you go to your DWI and ADC maps. That's what you're looking at. Then look for various pathologies. You're looking at mass effect. Is there a midline shift? Is there any herniation? If you can see any edema, for example, edema would be more prominent on FLAIR scans. You're looking at any hemorrhage that you have. Then you're looking at any infectious process, for example, certain ring enhancing lesions would commonly be abscesses. Then at the end of it all, ladies and gentlemen, I would want to tell you that imaging of the brain or imaging of anywhere is an adjunct to your clinical acumen. So talk to your patients. That's why you spend 6 years of your life uh, learning how to talk to patients, because the patient is what they tell you is what will guide you. If it doesn't tally with what you see on the scan, you need to be able to go back to the patient and ask some more detailed history. So clinically correlate what you see with the patient history. Next slide, please. Okay, so I think we've gone through this. As I told you now, depending on the physics of the MRI, we're looking at changes in tissue density, a presence of lesions that are not supposed to be in areas where they're not supposed to be found, and abnormal fluid accumulations. Next slide, please. So we'll try to touch briefly on common pathologies. Don't worry, I'll be done before 8 p.m., so I won't take too much time. So we can go to the next slide. So one of the ways of looking, or one of the common pathologies that we have presenting in the brain is an ischemic stroke. So an ischemic stroke is defined as reduced blood flow distal to where the blockage of the vessel is, and it causes what we call an infarction. So MRI findings, you would see, for example, on T2 on FLAIR, they would appear as hyperintense. So sometimes you would see, if you go more into more detail when looking at strokes, you have changes in the infarct that would happen over time. So after 6 to 12 hours, it would appear as hyperintense. So the keyword to use here is hyperintense. Then ADC would show you it being hypointense, and there would be restricted diffusion because there's minimal. Remember, DWI and ADC, we say it's looking at the motion of the molecules, and there would be restricted diffusion on DWI. And you confirm this using a MRA, which is a magnetic resonance angiography, and you would be able to see which particular vessel has been occluded and stenosed. Then you look at the neurological deficit in the patient. For example, if you're looking at the middle cerebral artery in a patient at the level of so middle cerebral artery is divided, for example, just this is an example. You don't have to know the specific details, but you'll see a patient, for example, who has presented with a middle cerebral artery M4 segment, ischemic stroke. So you would see that the pathology would be in the segment of the cortices relative to being an entire hemispheric acute ischemic infarct. You would see a patient, for example, presenting with the middle cerebral artery segment at M1, and you would see the deficit would be much more prominent. If it's in the left hemisphere, they would probably present with maybe speech abnormalities, with limb weakness, with convulsions, etc., etc. So MRA would help you find out your MRI findings. Next slide, please. So intracranial hemorrhage, there are various. We've covered this in great detail before. You're looking at the epidural, subdural, subarachnoid. So the findings would vary by the age of the bleed that you would have, but commonly on T1, T2, they would appear as bright, and T2, they would appear as bright. But again, it depends on the age. On the GRE-SWI, which is similar to almost DWI ADC maps, you would have that blooming artifact for blood. However, notably, blood is not very good to be picked up on MRIs. It's much more prominently picked up on CT scans, but you can still be able to pick it up on MRI if you want to define it much better. Next slide, please. Brain tumors, this is the bread and butter of MRIs. So depending again on what particular tumor its characteristics. You would have some tumors that are much more fibrous. You'd have tumors that are much more cystic relative to the other. For example, tumors such as a pilocytic astrocytoma would have, or a hemangioblastoma, as an example, would have a larger cystic component, whereby it would appear as bright on T1, but on flare, it would not be suppressed because it's different from CSF. So again, it's just good for you guys to have an idea. I'll also be honest, again, there's so many different tumors that are there. So you cannot be able to see and memorize each and every single one of them. But over time, the more you look at various MRI brains, the more you just pick it up, you can be able to tell it the common ones like gliomas, meningiomas, hemangios, pilocytic astrocytomas. You're able to see them more prominently. But even me, if you bring me the certain MRIs today, I would probably be having almost no idea about what they are, but I can correctly be able to describe the features. So the aim of the exercise tonight is not to memorize what are the specific features for each common pathology in the brain, but to be able to just at least be able to describe, is this lesion hyperintense, hypointense? What sequence are we looking at? Is it a T1? Is it a T2? And why is it appearing at that particular way? And then you probably have maybe 3-4 differentials that you're looking at in that particular region. Next slide, please. Demyelinating diseases, quite common, especially in neurology. An example you would have is like in multiple sclerosis. On T2 flare, there would be hyperintensities that are seen. Then on T1 post contrast, there would be an enhancing mass. Sorry, no, this is actually, I think this slide should have not been here. My apologies. I'll change that slide and send the right one. So on demyelinating diseases, you will have a lot of hyperintensities, especially within the white matter, especially with regards to destruction of the myelin. An example is in multiple sclerosis. But commonly, you'll have to correlate that with what you see clinically. Next slide, please. Now, there are certain pitfalls that you want to avoid in MRI interpretation. There's what we call motion artifacts, which sometimes will mimic a lesion due to movements you would get in the patient. There are normal variants, especially in anatomy. I know you guys have gone through variants in patients. There's sometimes what we call blurring at tissue interfaces, known as spatial volume effects. Occasionally, you would have misinterpretation due to common or normal age-related changes, like some calcifications of choroid plexus in the brain as you grow older, and you would think that that is a lesion. And the idea, or how do you take care of this? I recommend that you compare with prior scans. And the most important one is correlate clinically what you see in your patient with what the scan shows you. The scan is just an adjunct for you to be able to make sense of what you're seeing in the patient. Next, please. Good. So in conclusion, I think we have tried to make some bit of head and tail. In summary, we've talked about an MRI and how an MRI forms the images. We've talked about the advantages and disadvantages of MRI scans with a focus on the brain. We've talked and discussed about the various sequences of MRI and why they appear certain ways in terms of the intensities. We have been able to discuss how to read an MRI in an OSCE station as an example. You go through the various steps and try to come up with a pathology. And then we've gone through some different pathologies you would see and how they would appear. And finally, what pitfalls you can be able to avoid. Thank you very much. I think that's all I had for this evening. I would welcome any comments, additional points from the audience, or any questions. Thank you. Are there any clarifications that any of the audience members would want to ask? The trick again is also, especially for those of you I know who we have met in the ward, each patient, just pick one scan, look at it, try to sort of engage yourself, look at what particular scan is it? Is it a T1? Is it a T1 with contrast? Ask your colleague, see if they agree with you. Have a defensive, like defend your points why you think it's a T1. Your colleague can defend them why they think it's a T2. And you'll see within a week or two, the more you look at the scans, I promise you, you'll be able to get and make head and tail out of it. Then now go through and read the clinical correlation of what you're seeing on the patient and whether it makes sense. Thank you very much. Back over to you, Sadia.
Thank you, Dr. Mohamed, for that enlightening and practical presentation. We are deeply grateful for the time and knowledge that you have shared with us this evening. We also want to extend our thanks to everyone who has attended today. We hope you found the session as enriching as we did. On behalf of MSAUN KNH Academics Department, we wish you all an enjoyable and productive evening ahead. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. السلام عليكم ورحمة الله وبركاته.